Hi, my name's Irralee Andrzejowska, and I'm a physiotherapist and SIRPA practitioner. And this presentation is titled The Missing Pieces of the Chronic Pain Puzzle, the Mind-Body Perspective. And I would like to share with you how I've come to really enjoy treating chronic pain conditions, mostly because I've found these missing pieces through the mind-body approach. And as a result, have been able to lead clients to a full recovery from chronic pain, and this is incredibly rewarding. So allow me just to set up my slide presentation, and I'll go on to explain how I came to love the mind-body perspective and chronic pain. Okay, so here we go. So my journey to find the missing pieces started with my physiotherapy training in Sydney, which I graduated in 1990. And mostly I've been working in private practice. Now, although I'm dealing with a different cohort of clientele who certainly haven't got the challenging socio-economic conditions that many clients have in the NHS, these people, despite that, still suffer with chronic pain. So this was frustrating to me. I've been on lots of courses in my career and trying to work out how to solve this chronic pain conundrum. And this is what led to me reading further and finding more information. First of all, coming across the pain science revolution headed by Professor Lorimer Moseley and David Butler. Lorimer Moseley is a very amusing Australian neuroscientist and physiotherapist, and he presents the neuroscience revolution, which is a complete paradigm shift in the understanding about pain. And I'll be explaining more about this shortly. Also, I read a book called Healing Back Pain by Dr. John E. Sarno. And Dr. Sarno was a professor of rehabilitation in New York. He died a couple of years ago, age 94, but he came to discover through his own clinical experiences the radical idea that their chronic pain was being caused by repressed emotions in response to stress and trauma. And by approaching it this way, he was able to achieve incredible recovery rates of up to 80% full recovery in his chronic pain patients. Despite this, he was ostracized by his medical colleagues throughout his whole career, despite these amazing results. However, his work has been carried on by more physicians and therapists since then. And in particular, Georgie Oldfield, who is a physiotherapist in the UK, who was suffering with her own chronic pain. She went across to America to spend time with Dr. Sarno to learn about his techniques. And then she came back and in 2012 set up SIRPA, which stands for Stress Illness Recovery Practitioners Association. And with this organization, her aim was to train up other clinicians, and we've had, physiotherapists, chiropractors, osteopaths, psychologists, psychotherapists, doctors, and coaches train with this approach, and so that chronic pain sufferers in this country could also benefit. And I've also done some training in something called embodied processing from the Centre of Healing in Australia, and this involves dealing with trauma in a somatic way. So not talk therapy, but dealing with the effects of trauma in the body, the neural imprints, and working with those sensations to rewire the traumatic effects in the nervous system. So as we know, chronic pain is a major crisis. It's a huge cost on the individual, the family, and society. And the figures speak for themselves. Even though in our Western world we've got an incredible boom in how we understand and treat a lot of disease and lots of different techniques of treating it and medication and ways of investigating. In conjunction with this rise in medical knowledge, there's been a rise in chronic pain as well. In America, it's even more extreme. It's estimated that it costs America $635 billion a year in chronic pain costs. And this is more than cancer, diabetes, and heart disease combined. So it's a massive issue. And the problem is that chronic pain won't kill you, but it will certainly cause a lot of disability and dysfunction. and it's something we need to solve. The current state of the treatment puzzle is this. We have the NICE guidelines recently, which identify we need patient-centered care, understand the psychosocial aspects, and teach coping and pain management strategies. It recommends that what is proven to have an effect on this is cognitive behavioral therapy, acceptance and commitment therapy, and amitriptyline is the only medication advised. A recent review of CBT and ACT, however, has found that there's small positive effects on these psychological therapies in chronic pain. So it definitely does have some impact on catastrophizing and disability, but has been shown to have no significant influence on pain or mood. And this is because of the limitations of this approach. So these type of approaches for chronic pain that are currently being used are treating the symptoms without that understanding of what the root cause is. And I'll be talking about what the root cause is as far as the mind-body approach is concerned. And when you deal with the root cause, you can resolve the problem, but not by treating symptoms. It's also about changing thoughts and not beliefs. Now, our beliefs are in our subconscious brain and they determine all our behaviors. And these are very important to change if we want things to be different. And the whole sort of premise behind CBT and ACT is teaching coping methods and managing pain, and it has no aspirations to cure. So this is what our chronic pain patients look like when they turn up. They're literally on their knees and their life has come to a complete standstill. Now, looking at this image, you can probably understand why CBT, ACT, amitriptyline would have absolutely minimal impact on this donkey being able to get back up on his feet again and get going in life. And it seems obvious that, this donkey's probably got knee pain, a dislocated hip, neck pain, ulcers on its mouth. And however, if you treat those symptoms and give him some cream for his ulcers and massage his knees and give him a hip replacement and give him some neck exercises, you can see why that's not going to solve the chronic pain problem. What's different about the mind-body approach is it looks at the reason why the donkey is on his knees in the first place and looks at all the load that he's carrying on his back, all those bricks, which is all the stress and trauma that the client is carrying in their life, which has just brought them to their knees. And you can see why the mind-body approach is quite different in how it addresses chronic pain. And this brings me to the 6 puzzle pieces and how it is different. The first one being that chronic pain is rarely caused by structural damage. So I'm going to talk mostly in terms of low back pain for simplicity in this talk. And it's estimated 1% of low back pain is due to a red flag. So that could be inflammatory disease, tumor, fracture, cauda equina, this type of problem. 5% due to disc prolapse with nerve root compression, and this type of problem responds very well to surgery. But 94%, there's no definitive diagnosis that can be found based on scan and structure. What we do know is, as a fact, is that all tissues are structurally healed after 3 months. So whether you've had surgery or you've had an injury, if you've got pain ongoing after 3 months, it cannot be ascribed to structural damage. Pain after this time is being caused by neural pathways coming from the brain. And this is therefore where treatment should be directed if the pain is to be resolved. But most chronic pain sufferers and their healthcare providers believe that their body structures are fragile, broken, degenerating, they'll never recover, and they should protect, embrace, and avoid activity in order to protect their vulnerable selves. And all of this fear that is produced by sort of scary MRI results and beliefs keeps people stuck in the pain-fear cycle, which is chronic pain. Changing these fearful and inaccurate and avoidant beliefs is absolutely essential for recovery. And this is one aspect the mind-body approach works on. There's a lot of evidence for non-structural causes of chronic pain. So in the biomechanical literature, there's been a review, a big review, and there's no evidence found for a relationship between posture or pathomechanics as the cause of chronic pain. So what this means is that perfect posture and perfect alignment of the body structures does not prevent chronic pain, and correction of it does not cure chronic pain. And the same thing goes for core strength, which has been often touted as a cure for chronic back pain. In fact, it's the opposite. So if you put EEG onto chronic back pain sufferers, you'll actually find that there's excessive activity in their abdominal wall and back muscles. So they're actually in a constantly braced state. And this is due to fear and trying to protect what they feel is vulnerable. People believe they've got a disc that's going to pop out the next time they bend over. So they're constantly bracing their body. And this overactivity, you can see why doing core exercises and learning how to brace your body harder is certainly not going to be the answer to solving a problem which is already caused by overbracing in the first place. Looking at ergonomics as well. So there's this big study looking at office workers, the incidence of low back pain, and trying to find the common denominator. And what they found that was the most predictive factor of low back pain in this population was not the chairs they were sitting on or how long they were sitting there or the posture they're in, but was psychological factors such as fair leadership or decision control. They were the factors that determine whether someone developed back pain or not. Looking at a more active job like student nurses, again, the incidence of low back pain could not be linked to the physical work activities or incidents, but to pre-existing stresses, which were common in those who developed back pain. In a lumbar surgical study, it's found that the poorest outcomes are those who had high psychological risk factors as found by screening, and that these poor outcomes could be predicted with good accuracy. And you could argue that before having any lumbar surgery, for example, if their psychological screen showed up these psychological factors, you could, maybe suggest that surgery is not going to be beneficial for this group of patients, and so they can look towards a more psychological approach. This slide is from a study looking at scanning people who don't have pain. So traditionally, people used to have MRI scans. Only people who had MRI scans were those who are in pain, and all these abnormalities would turn up, and therefore it was assumed that these abnormalities must be the cause of the pain. But because it didn't seem to stack up that when you chopped that bit out or injected it, their pain went away, they decided to do some imaging on people without pain, and this is what they found. So we're keeping in mind that these findings are in asymptomatic people. And if you look down the list of your age bracket, you'll see the possibility of you having these different degenerative changes. Now, these are in pain-free population, and there's no correlation to pain. Dr. John Sarno called these normal abnormalities, just the wrinkles on the inside that come with aging. You'll notice when you look across the table that all the figures start lower and gradually increase through age. Now, if these degenerative changes were correlated with pain, you'd expect that the sort of graph of pain through life would kind of look like this exponential curve. But that's not what the graph of pain looks like, low back pain in the population. In fact, the most prevalent time for low back pain is found to be between the ages of 30 and 60. So the graph looks sort of more like this. So that is not in conjunction with the progressive degenerative changes that are happening naturally in the spine. So we need to question what we see on these scan results. The problem is that the scan results and all these reports of degeneration and bulging and this type of thing is sent to the client, to the patient, and they're very, very scary report findings. And if they don't understand, because it hasn't been conveyed to them that these are normal changes and very unlikely to be the cause of their pain, they're naturally going to be fearful and worried about these results and become fixated on the fact that their body is broken and damaged. What an MRI scan is very good for is to rule out the red flag causes, but we need to look more closely at the reason for people's pain and not treat the scan if we're to accurately resolve someone's chronic pain. You might think, well, maybe these people in this study had all those changes and didn't have pain in their back because maybe they didn't use their body very much. But they've done MRI studies on athletes who we can argue put their body through a full extreme of loading. And they had a look to see on the relevant joints for each sport, the incidence of abnormalities on the MRI in pain-free athletes. And as you can see from these results, it was quite a significant amount of these changes that you would normally consider to be pathological and require surgical treatment of. And all these athletes were performing top of their game with these abnormalities without any pain. Again, questioning that relationship between these findings and pain. This is an MRI scan of a lady, and she had, as you can see, a massive disc protrusion, L5-S1. And what is interesting to note is it was compressing both her S1 nerve roots. But in fact, she only had symptoms down one side. And she had sciatica down her right side. She also had some muscle calf weakness and loss of her ankle reflex, even though the report is showing bilateral effects. So again, there's a mismatch in the clinical signs and the report. And in fact, she recovered fully. She became pain-free after 2 months with a mind-body approach. And a few months later, full resolution of her calf weakness and her reflexes. This is an MRI scan of a young pregnant lady, and she had no symptoms. And now, if this MRI scan came through and someone had, just fallen off a major wall or something, this could be the type of finding that came in a traumatic event. But in her history, she'd had no trauma. This is obviously congenital change in her body. It's only when she happened to have a scan for other reasons in her pregnancy that it came to light, and she was completely pain-free. So the important thing to note is that all pain is real, but it can be an inaccurate indication of the presence or extent of tissue damage. And this is what the neuroscience is now proving to us. So the equation is that pain does not equal damage. This case report was reported in the British Medical Journal of a construction worker who accidentally got a big nail driven through his boot. You can see it coming through just above the toe cap there. Now, for this man, he had extreme pain. And when the ambulance came and they gave him IV drugs to analgesic, it didn't touch the sides. He was still in agony. He got to A&E and they managed to pull out the nail and take off his boot. And to their great surprise, there was absolutely no tissue damage. And what had actually happened is the nail had gone between his big toe and his second toe. And when, of course, he saw that there was no damage, his pain immediately stopped. Now, his pain was absolutely real, but you can make sense of it when you understand that pain is the brain's opinion about threat. And for him, having a nail through his boot was incredibly threatening, because not only was it a threat to his body potentially, but a threat to his self-employed lifestyle, self-employed employment, and paying the mortgage, and his ability to provide for his family was also under threat. And this created an even greater pain signal. So this brings us to the next slide, which is the puzzle piece that all pain is produced by the brain. And that's in acute pain and in chronic pain. So originally this diagram here, we're familiar with the René Descartes model of pain from the 1650s, which was that we had these pain receptors that detected pain, and this pain message traveled up pain neural pathways and announced to the brain that pain has arrived. Well, the modern neuroscience, which has been around for at least 15 years now, has completely turned this on its head. And we now know that there's no such thing as pain receptors and pain nerve fibers. We do have receptors called nociceptors in our tissues, which detect mechanical, chemical, and thermal inputs. Those inputs then travel up the fibers to the spine, which we previously called pain tracks, but it's just data going up from these receptors into the brain. And in the brain, this information from the tissues is summated with the information in the brain. So this is memories, beliefs, expectations, culture, emotions, all mix in. And the output is pain if the brain perceives that all this information indicates threat to the individual. So once again, to emphasize that pain is an output of the brain, not an input. And this is a game changer in understanding pain and how to treat it. Pain, in fact, can be considered to be a danger alarm in response to a threat. But as humans are very complex, the threat could be physical, but it also could be psychological, social, or emotional. So it's like thinking of, say, an alarm, it's a fire alarm's going off. Now, if you turn up at the fire and you hear the fire alarm, which could represent that where the pain is in the body, say in the back, if you go and just go into the house and rip off the alarm off the wall, you're not actually dealing with the source of the threat, which is the fire on the other side of the room. The mind-body approach actually deals with the fire. So not the source, not the site of the symptoms, which is where the alarm is sounding, but the source of the symptoms, which is in the nervous system. And this is why it's such a different approach. And this is why it can be successful, because it deals with the root cause. Also in chronic pain, this danger alarm of pain is sensitized so that even normal inputs are interpreted by the brain. So even normal inputs of maybe stretch or compression coming from body tissue, say like the low back, can be interpreted by the brain as dangerous because of the belief that that area is fragile. And the brain therefore produces pain because it perceives danger, because it perceives it, even if there isn't any real danger. And this is similar to if you have a fire, if you have an alarm at home, say a burglar alarm, and if it's set to super sensitive and it notices a spider going across, and it's set off by a spider rather than a burglar. So the sound of the alarm is exactly the same, whether it's a spider or a burglar. And the same for pain. You can't tell by the quality or the intensity of the pain whether it's a false alarm or whether there truly is tissue damage in the body. And that comes with much further inquiry and questioning and understanding the behavior of pain and how the brain is involved. And then you can understand what if there truly is tissue damage or not, and treat accordingly. Now, once you have explained to the patient that their pain is not coming from damage in the body, they then often swing completely to the other side and in indignation and say, well, are you saying this is all in my head? Now, and this creates a big stigma and resistance to the idea. And it's not in your head in the sense of it not being real, because all pain is real. It's not due to mental illness, and it's not being made up or imaginary. So it's not in your head in that sense. But the fact is, it is in your head in the sense that all pain, acute and chronic, is produced by the brain, which is in your head. And so in that sense, it is in the head, but it's a different understanding from what people initially fear. So the third puzzle piece is that chronic pain is a software problem. And so we need to work on the software, not on the hardware. It's caused not by damage in body structures, as was and is often believed, but it's caused by neural pathways in the brain. Functional MRI studies of chronic pain patients have shown that there's increased activity in the emotional centers of the brain, not in the somatic areas, as you might expect. And there's also thinning in the dorsolateral prefrontal cortex, which is an area of the brain which helps modulate and down-regulate emotional center activity. And that's less effective as well in chronic pain patients. And what happens is we develop these conditioned fear pathways so that certain physical triggers become associated with pain. The brain learns pain, and the brain is a predictive coding machine. So, for example, for a patient who might associate a low back pain patient bending or sitting with pain, every time, for example, they go to bend, their brain is automatically predicting that it's going to hurt, so they brace their body, they hold their breath, they do it in a sort of rigid way. They've got all their attention on their spine. They bend over. It causes pain, of course, and this reinforces the learned pain cycle associated with this movement. So the mind-body process, understands within neuroscience that the brain pathways are neuroplastic, and this pathway can be changed by changing the beliefs and creating an corrective experiences that change the wiring and the belief and the outcome of bending to the point where you can quite quickly, for example, within a session, when someone's on board with the idea of the neural pathways, that and you can train the bending movement, for example, to actually become neutral and even enjoyable. And once there's no fear attached to the actual movement, because the brain doesn't detect any danger and with no fear, then it becomes pain-free. And the best way to really demonstrate to someone that their pain is as a result of neural pathways and not structural damage is by doing this visualization. Now, I had a patient just recently who, over a year ago, experienced very acute pain in his back during a golf swing. And ever since that time, he's been, terrified of rotating his body and therefore hadn't been able to get back to golf. And I just had him standing and asked him to close his eyes and assess how much pain he had currently as just standing still. And then I had him visualize swinging a golf club, getting out the driver and giving it a good old whack, just in his mind. And in doing that visualization, he had this fear response. He started to feel some anxiety in his chest, and his pain increased right in the moment. Now, this is a really powerful way to demonstrate, as I did with this patient, that here he hasn't moved at all. There's been no change of load on his lumbar tissues, and yet his pain is dramatically increased. And this is great evidence for the patient that the pain's being caused by neural circuits and not by damage in the body itself. And we have to change the beliefs, the movement programs and triggers in the subconscious mind. It's not good enough just to say, oh, bending over is absolutely fine, off you go, and they bend, and of course it's not. It's got to happen at a deeper level. We've got to change those deep beliefs, and we've got to give them new information and new experiences of movement which change these movement programs. The fourth puzzle piece to look at is the impact of stress. And one of the most important questions to ask someone when their pain started is, what was going on in your life when the pain started? And very often the first answer is, oh, nothing, just the same old stuff. So I often pause and I might ask the question a slightly different way. Or they might have their partner with them in the session, which is incredibly helpful, because they'll then pipe up and say, oh, yeah, wasn't that the day your sister went into hospital seriously ill? And the chronic pain patient hasn't joined these dots up at all. And often other people can see them when the idea is presented to them that that stressful events can have an impact. And this is how you can understand. Now, it can also be the case that if you've had an accident or had surgery and you've gone on to have chronic pain, if you inquire as to what was going on in your life at the time you had the accident or at the time you had the surgery or during the recovery period, again, you may find there was something stressful going on in their lives which could account for why the pain continued after the healing time in a way which you wouldn't normally expect. And the question is about the stress. Now, there's different types of stress. We have the busyness of everyday life. So there's absolutely nothing wrong with being busy as such, except if it's to the extreme that you neglect self-care, that your nervous system's in a constant state of fight and flight and doesn't have the time to calm down, come into rest and repair and recover. That's when it becomes a problem for the health and well-being of the body. We have the impact of stress of childhood. So as we're growing up, our autonomic nervous system is developing its set point for where it detects danger. So if you've grown up in a stressful environment, your nervous system, your autonomic nervous system, your survival responses are going to be more wired towards tripping off in that danger pain signal more easily. It's going to be more sensitized as you go through adulthood and come across more stresses in life. The stresses of modern day life with all their electronics mean our nervous system's often overstimulated and overwhelmed by the stimulation, and not really much downtime, just when there's just peace and calm for the nervous system to recover and reset and be ready for the next challenge. Because it's not stress itself that's the problem. It's the emotional reaction to the stress and the danger that is detected in the stress. I'll explain a bit more soon. And the other source of stress is the personality traits. The most common personality traits found in those people with chronic pain are perfectionism, people-pleasing, over-responsibility, being over-analytical, being a goodist. And these are qualities, these are learned survival behaviors. Nobody's born a perfectionist, for example. These are behaviors we learn to survive as we're growing up as childhood in order to achieve or maintain attachment to our caregivers. And it's often quite successful. It gets us maybe a lot of friends and support and praise and admiration from our family, friends and society, being these things. But it comes at a huge cost to the individual because they are putting enormous pressure and stress on themselves and often neglecting their own needs. And this creates a chronic physiological stress response in the body, which is chemical and hormonal and neural responses, which means the body is not in a state of well-being. Now, this is how chronic pain patients drive their cars. They've got their foot flat to the floor on the accelerator, and they've also got the handbrake on. So they're just going round and round in circles and burning a lot of rubber. Now, if we take this metaphor further and we took the car to the mechanic, he's going to examine that car and run some tests on it and say, yep, got all the working parts. It's all working fine. I can't see there's any problem. I don't understand why you're having problem driving this car. I can see you've got a bit of wear and tear on those back tires, so I'll change them for you. But you can see how, changing that wear that's showing up is not going to make any difference when the mechanic can't find any problem except that, and the person actually goes back to driving like that. So we're talking about how people are using their nervous systems in their bodies, which you can't detect on a static test, but you can detect when you ask more questions about how they're running their lives and what's going on for them. So what happens with chronic pain patients? They're operating in a chronic sympathetic drive. They're in constant survival mode, which takes a lot of energy. It also impairs their immune system. They become prone to all sorts of infections and other problems. And because they're using up all their energy in survival mode, and there's no time or energy to thrive or grow. And they're constantly wired and tired because they can't sleep. They can't calm down the nervous system because they're just sort of constantly in this adrenalized state, and they don't have the tools to calm down their nervous system and achieve rest and repair and recovery. If you're interested in the effects of stress on the body's health, I recommend this book by physician Dr. Gabor Mate, When the Body Says No. I'm from a crazy cat family, so I wanted an opportunity to put some cats into this presentation and to demonstrate the difference between different nervous system states. Now, ideally, we want a nervous system like the comfort cat on the left. He hasn't had any intergenerational trauma. He's had a non-traumatic birth. He's had a life of loving, warm comfort and safety. And so he's able to fully relax. And he's got a nervous system which is flexible, so he can respond to threat. So when the 2-year-old comes around from next door, he can spring into action and avoid the threat and run away to safety. And then he can get back into relaxing again in a pretty flexible way. And that's how we want our nervous systems to be, operating in a sort of default relaxed state and just activating it when there is an acute threat presented, and then being able to return back to that relaxed state when the threat has passed. On the other side, the feral cat, he's born into a situation where the environment is dangerous. He's having to stay on high alert to danger. So he can't relax easily. It's more difficult. He has less time to be able to get into rest and repair. And you can see what a ragged state he's in as a result. So there's a big missing piece, the biopsychosocial pain model, I would suggest. So we know about the biology, the tissue effects, the social, so the environment people are living and working in, the psychological aspects, so anxiety, depression, or what's going on in our minds. But the big missing piece as humans is this emotional piece, which is the next puzzle piece. Human beings are emotional creatures, and this is very much part of our experience, which has not been included. And the International Association for the Study of Pain definition is that pain is an unpleasant sensory and emotional experience. You can't have one without the other. Now, we know that pain creates an emotional reaction of fear or frustration, disappointment, and many other emotions besides, but it works the other way around. Emotions, when they're repressed, can also cause pain. So this is the breaking news. I mean, it's not breaking news in that it's only just occurred. It's been known by Dr. Sano, certainly from 50 years ago. But this is what's breaking news to myself and many of us who have been biomedically trained and in our Western society led to believe, and that this information is that repressed emotions can cause pain. And, this was a big kind of paradigm shift to make, to understand that this is possible. And I'm going to explain a little bit more about that, so I hope it makes sense to you. The thing is that our issues are in our tissues. We kind of know that. So what happens is our nervous system, as we're in childhood and it's developing, it can learn through its experiences that there's certain emotions that are dangerous, and that these emotions become wired with an anxiety fear pathway. And so we get like this twinned pathway between an emotion being evoked and a fear response being evoked. So what happens in later life as an adult, if this dangerous emotion is evoked in a stressful life event in adulthood, that can trigger a physical pain if the emotion's evoked and it's repressed due to the fear of that emotion. And I'm giving an example in a moment to demonstrate this. And then what happens is, so what's happening is the nervous system in that moment reflexly decides that physical pain is safer than emotional pain, and it provides this somatic distraction in the body. Because emotions, when they are created or evoked, they do not just go away if you don't feel them consciously, but they can be converted into the somatic pathway and present as pain and tension in the body if they're being repressed due to fear. So an example of this is a client I had who had chronic back pain for 10 years. And there was no, structural reason for this on further questioning and testing. And when I inquired a bit more about his childhood experiences, so I could get to know the state of his nervous system wiring, he described that he had been bullied at school by bigger students, and it made him tearful, and he got very teased about that when he had cried in response. And he also had a rageaholic father. And on one occasion, significant occasion, when he was 12, and there was a big argument in the household, and his dad threatened to leave the family and walked out the door. And this client, burst into tears, understandably. When his dad came back in, and he shamed him for crying and told him to buck up and stop crying, and men don't cry, get over it, don't be such a wuss sort of thing. So these repeated experiences this client had taught his nervous system that to express grief and to experience grief was dangerous, not only to his connection to his caregiver, but also to his concept of manhood. And so his nervous system learned that if these emotions get evoked, they should be repressed. Well, when I inquired about the onset of his back pain and the timing and what was going on in his life, of course, at the time, everyone blames it on a physical thing. I think he blamed it on doing some gardening or something like that, and his back pain started. But when you actually ask what was going on in your life at the time, because if you like, the gardening movements just exposed the tension in his body. It wasn't his body was already in that state of tension. He had a major breakup of a romantic relationship, someone he was very much in love with. And at the time, he didn't really experience the grief of this, this big emotional event in his life. But instead, what happened? He developed very acute, severe low back pain, which continued for the next 10 years. And once we were able to convince him that he didn't have a structural cause and that there was this emotional relationship, and then teach him how to reduce the fear about feeling the emotions and where this came from, and using techniques to express these grief emotions safely so they could be released from his body, his pain fully resolved. Because emotions, think of the word emotion, is energy in motion. And they've done studies on this. Emotions are supposed to be felt, and they can be felt for an average of 90 seconds. They're supposed to rise up on us and then fall away. The problem is if they rise up on us and they're repressed, they get stuck in our tissues and they remain there. So rather than it being a 90-second phenomenon, it can be a 90-year phenomenon if it's not addressed. But equally, even if they're stuck, we can go back in and release them so they're no longer in our tissues. And the last puzzle piece is trauma in chronic pain. And the question is not what is wrong with you, but what has happened to you. And it's only when you ask these questions of chronic pain patients that you can start to join up the dots and help them understand the reasons why that they're in pain and their relationship between their traumatic experiences and their nervous system state. This incredibly important study done way back in 1998 was the Adverse Childhood Experiences Study, a large study, and it demonstrated the devastating link between childhood adversity and poor adult health behaviors and disease, including chronic pain. Now, the ACE report came up with a 10-point scale of different categories of physical, sexual, emotional abuse, neglect, mental illness in the family, loss of a parent due to death, divorce, jail, or witnessing violence. And you can give an ACE score sheet to a client and find out what their score is. And there's much more information you can look into this study. But just to give you an example, if your ACE score is 7 out of 10, and this is not incidences of trauma, this is 7 different categories, your average life expectancy is reduced by 20 years, such as the impact on our adult health that these early experiences have. If you want further information about the impact of trauma on the body and health and disease, I can highly recommend these books here. The Body Keeps the Score has got a lot of the science and research. So if you like that type of element, you can get right stuck in with that book. And The Myth of Normal, that's just recently come out, as an incredible book explaining how very often it's the society that we're living in, the petri dish that our nervous systems are in, which is causing the problem, not an internal flaw of the person. So they did ACE scores on people in chronic pain, and they found that between at least 50 to 60% of people had a trauma history. And this is really relevant to know, to help people understand, but also so that trauma can be dealt with. And the most effective ways of dealing with the trauma is not necessarily through talk therapy, but through somatic type approaches that deal with the imprint in the nervous system to resolve these fears and imprints. And that's what I was explaining about the embodied processing earlier. Now, what's also very interesting is the incidence of that women versus men in chronic pain. FM, fibromyalgia, autoimmune diseases and chronic pain, you can see it's like, 70 to 80% of sufferers are women. And this is the same proportion in chronic fatigue and also IBS, for example. So many women are suffering from these conditions. And there's various reasons to explain that. I would suggest it's not to do with being female as such, but it could be that females process strong emotions, especially anger, inwardly rather than outwardly, as a man might more tend to do because of how we've been socialized. Also, women are more likely to have had a trauma history, and they're more likely to maybe have some of those personality traits such as over-responsibility and people-pleasing, which means they neglect their self-care and their own needs, which are significant factors in developing chronic pain in the first place. So chronic pain is this vicious cycle of fearful beliefs and vigilance, and the autonomic nervous system being in sympathetic drive and sensitization of normal inputs, avoiding behaviors, and lots of emotions being evoked because of that. And the mind-body approach intervenes at each of these boxes to address and resolve the aspects that are fueling this vicious cycle. And when we do this, we can end up with the donkey standing back up and miraculously also looking younger. And the point being that he's still got some load on his back, and we don't have to remove all the load that someone's carrying, but certainly get it down out of this overwhelming load that he was carrying before to one that's manageable, so that he can get back up onto his feet and become more resilient and get moving forward and enjoying and thriving again in his life. Now, where are the studies? I hear you cry. Well, there was this randomized control study that came out at the end of last year and reported in JAMA Psychiatry. And there was 151 patients with chronic low back pain, average of 10 years, and 50 of them received an aspect of the mind-body approach, which is the pain reprocessing therapy, which is basically about changing the threat meaning to pain with education, and then giving corrective experiences of people moving and using their body and relating differently to their pain. So they had some sessions of this and then compared it to open label placebo. So people were told they were getting placebo injection of saline into the lower spine, but they still had the doctor all dressed up in the white coat, and they went through the procedure of being cared for and treated as a patient. And then 51 had their usual care. And the results speak for themselves. The percentage of patients that were pain-free or nearly pain-free at 4 weeks, which is either a 0 or 1 out of 10 on the pain scale, was 73% in the PRT group, 20% in the placebo group, which is what we often expect with placebo, again, demonstrating the power of the mind and the belief, and maybe the interaction with the person injecting the drug, which led to some improvement there, and 10% in the usual care group. And also there were functional MRI changes in the brain in the PRT group. So this type of treatment is changing the brain, and this is where we propose that these changes need to happen in the brain and not in the body, and it's actually been shown on the functional MRI that this is what's happening. Another RCT was comparing different therapies in the treatment of low back pain. The PSRT is a long-winded word for psychophysiologic symptom reduction treatment, compared to MBSR, which is mindfulness-based stress reduction and usual care. And the percentage that were pain-free at 26 weeks was 63.6% in the PSRT arm, which is an aspect of mind-body treatment, 25% in the mindfulness-based, and 16% in the usual care. And this study compared treating fibromyalgia with either emotional awareness and expression therapy, EAET, and cognitive behavioral therapy, or just education. And they decided to measure it based on the left-hand graph there of whether they had achieved 50% or more in pain reduction. And the results were that in the emotional expression, which is again an aspect of the mind-body approach, using this strategy, they achieved 22.5%, had at least 50% pain reduction, and compared to 8.3% in the cognitive behavioral therapy group. And they concluded that emotional awareness treatments should be considered in treating fibromyalgia patients, for example, a very common chronic pain condition. There's also a lot of merit in case studies in that, you know, an individual who's been through lots and lots of different treatments for their same pain problem, which have failed, and then they have a mind-body approach and it is resolved, provides incredible hope and for patients suffering. And these stories of recovery can be found on these websites. And the PPDA associate, the SIRPA one is the UK-based one by Georgie Oldfield. The PPDA is the American branch. And these websites all have resources for clinicians and for patients. They also have success stories and online training for therapists, and also online recovery programs for patients. So great resources. Personally, I wanted to try out these techniques on myself. Fortunately, I don't have chronic pain, but I did manage to resolve my Raynaud's disease so that I can now do cold water swimming and not get any Raynaud's, which is incredible. And I've also resolved my long-sightedness using these mind-body approaches, so I no longer need to wear reading glasses. So in conclusion, the mind-body approach for chronic pain is evidence-based, and it basically is very holistic because it converges the knowledge of pain science, stress physiology, psychology, and emotional factors as well. And this means that chronic pain doesn't need to be managed. It can be resolved. And it can be resolved when these missing puzzle pieces I've been discussing are understood and addressed, and you deal with the root cause of chronic pain, which is actually in the nervous system and not at the site of symptoms in the body structures. Recovery is dependent on an acceptance of a paradigm shift by healthcare professionals and the clients about changing the idea from the structural model to the psychological and emotional model. But it also relies on the willingness and the readiness of the patient to change their beliefs and address underlying emotional issues. And, you know, they're not always ready for that. And we have to work with where they're at and maybe plant some seeds or share some information for them to read. And when they're ready, they can use this approach. And this is what happens. We get our nice donkey up on his feet, hopefully. But my hope for the future of treatment of chronic pain is that the mind-body approach becomes widely adopted and it's used as a first rather than a last option in the treatment of chronic pain. Now, I think I'll probably be holding my breath for that outcome, but ultimately that's what I hope will happen. And it's a big sort of growing revolution in treating chronic pain, and it's happening from the ground up, because when people experience the recovery through this method, you know, they are spreading the word, and often a lot of them are becoming therapists themselves, so that more people don't have to suffer like they have. And I'm hoping with the knowledge of this approach and its success, the ongoing research, and it will inspire clinicians to train and to deliver this approach to chronic pain patients who are desperate for a more effective treatment option, and for the clinicians to actually find that treating chronic pain rather than becoming a pain in the neck can actually become rewarding and enjoyable, as I found it to be. If you wanted to get in touch with me about anything that I've been talking about in this presentation, I'd be delighted if you sent me an email. And thank you for listening. I hope you've found some value in this presentation.